afternoon, everyone. Welcome to the Green Expert Talks. So today we have with us Dr. Sathya Rao, who's going to speak on treatment of borderline personality disorder. And I am Purnima Mahendru, who's going to be the host of this conversation for during this afternoon. And before we jump in, I would like to introduce our organization, the Green Initiative. The Green Initiative, for who are not aware, is based out of Bangalore. It is a community mental health center, and we are a team of psychiatrists, clinical psychologists, and counselors. The Green Oak Initiative was founded by Dr. Ashlesha Bagari and Dr. Soumya Krishna back in 2019. It's almost now 5 years that we have been able to establish a community mental health center in Bangalore. Some of the initiatives that we have taken up, apart from general psychiatry and psychotherapy, is Samartha, which is our low-fee clinic, where we offer low-fee services in both psychiatry and psychotherapy. We have Chiguru, which is our exclusive perinatal mental health service, which deals with perinatal population, starting from preconception to postpartum period. And along with that, we also have a specialized service in personality disorders, where we provide consultation in terms of psychiatric consultation, individual therapy, group therapy to borderline personality disorders. So welcome all. Now I will go and I will introduce Dr. Sathya Rao, and please stay with me because it's going to be a good, impressive introduction. Dr. Sathya Rao is an associate professor, and he's executive clinical director of Spectrum, which is a statewide service specializing in personality disorder and complex trauma. He's also the vice president of Australian Borderline Personality Disorder Foundation. He's the president of Australasian Association of Research and Treatment of Personality Disorders, and also chairs the Committee of Professional Practice of RANZIP. In recognition of his outstanding service to Victorian psychiatry, over many years, the Victorian branch of the College of Psychiatrists in 2020 had awarded him with the Meritorious Service Award. Along with it, in recognition of his contribution to psychiatry, he had received the award of the Medal of the Order of Australia in June 22. He's a psychiatrist and psychotherapist with training and background in DBT, MBT, ACT, and psychodynamic therapies. He has been actively involved in teaching and training activities across Australia for psychiatrists, GPs, and clinicians of allied health disciplines. He has been the head of the psychiatry training for Victoria and RANZIP. He has also held the roles of Director of Training, Director of Advanced Training in Psychotherapy and Adult Psychiatry, and has been a mentor for a lot of IMG psychiatrists. He was a member of BPD Guidelines Development Committee of National Health and Medical Research Council of Australia. Dr. Rao has been an invited speaker and has presented academic papers at national and international conferences, and also has published more than 70 research papers and has contributed extensively as chapters to books, and has co-authored books on personality disorder. Welcome, Dr. Sathya. Thanks for agreeing to be an expert in this month's expert talks. So before I hand over to Dr. Sathya, some basic rules of the talk. So I will be moderating this session today, and we want to keep it interactive. In case of any questions, either you can type in, I will be keeping an eye on it. If you would like to ask on your own, you can press the raise button, and in between, whenever I get a chance, I would request you to clarify or ask your questions. Just so that we can have a clarity. So I would request all of you to keep yourself muted till the time presentation is going on, and enjoy this afternoon. So over to you, Dr. Sathya.
Thank you, Purnima. That was a very, very generous introduction, and good afternoon to all of you. And my sincere thanks to Ashlesha, Devanshi, and Purnima, and the Green Oak Initiative. Looks like you're doing a great job. I'm quite impressed with the way you conceptualize the name of the organization. Building resilience. In fact, I should have titled my talk Building Resilience, now looking back, because that's what is the theme of the presentation. I titled the talk as Treatment of Borderline Personality Disorder. It's not rocket science, a very cliche word. The reason being, eh, I, 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 I've spent now nearly about 30 years um, uh, in psychiatry and about 27 years in the field of personality disorders. My take, initially I was trained in dialectical behavior therapy. That's what I thought was my passion, and I practiced DBT. I just literally stalked Marshall in hand and went and got trained from her wherever she went. Then I got bored by DBT a little bit after some time. Then I went to MBT, and we got Anthony Bateman to Australia, and we got trained in MBT. Then I did training in acceptance and commitment therapy, and my original training in India is in psychodynamic psychotherapy. But as I've grown older, what I've realized is that all these treatments are, you know, equally effective. Uh, they conceptualize differently, but it's all the same in so many ways. That's what I'm going to demonstrate today. Also, I think the treatment of psychotherapy itself and the borderline personality disorder treatment, which is psychotherapy, has been made out to be something which is only a very few people can do, and something which requires a lot of training and a lot of expertise. Uh, and that's what DBT and MBT taught us. Uh, so don't get me wrong, I'm not trying to bag DBT or MBT and at all. That's not my intention. Um, However, that has given a message to vast majority of the clinicians across the globe that treatment of BPD can only be done by some people. And vast majority of us can't do BPD treatment. I don't think that is true. So I believe that every mental health clinician is capable of providing treatment to people with borderline personality disorder and achieve good enough outcomes. So that's what I'm hoping to convince you today. So these are my gratitudes. I also want to acknowledge NIMANS. Uh, that's an institution where I come from. I'm very proud to be a NIMANS alumni. Spectrum is the organization that I direct, and Spectrum is a center of excellence for personality disorders in Australia. And we have some very passionate clinicians working there. I want to send my thanks to them. So I'm going to talk about borderline personality disorder. Although, um, uh, if you look at personality disorders, of all the different types of personality disorder, borderline personality disorder is the one which has been diagnosed and treated the most. When clinicians make a diagnosis of a personality disorder, 99% of the times it is for borderline personality disorder. And as such, the science that we have today and whatever evidence-based treatment that we have is for borderline personality disorder only. Of course, for antisocial personalities or narcissistic personality, there is some evidence being built up. When we look at established evidence, it's only for borderline personality disorder. And borderline personality disorder, however, continues to be highly misunderstood, very stigmatized. Clinicians are often unwilling to diagnose the condition because it has got such a bad name. And as such, a generation of mental health professionals have not been trained to treat and manage BPD. Certainly, people of my generation, we were never trained. And today we have several evidence-based treatments. We know that treatments work for people with BPD and we can achieve decent outcomes. So this is the point I was trying to make, that access to evidence-based care for people with borderline personality disorder is very, very limited globally. Um, Even in developed countries too. See, in Australia, very few people get treatment. I know in US it is much less. And I'm very pleased to know that in India, in the last couple of years, I've come to know that more and more access is being facilitated by motivated clinicians like yourselves. My thanks to you for that. So even to this day, we don't train psychiatrists, psychologists, general practitioners, and all allied health professionals in the treatment of borderline personality disorder. So psychotherapies as such are expensive. It takes time to provide psychotherapy in the way we have conceptualized it today. And also, treatment of BPD is perceived to be very difficult to learn, not only to provide. So what that makes is it makes it inaccessible for most people with the diagnosis of personality disorder around the globe. Just a few stats about BPD. Borderline personality disorder prevalence is at least 1% in the community. This is across the globe, very similar to schizophrenia and bipolar disorders. And for a long time, it was thought that it only impacted women, which is not true. Of course, in the clinical populations, women are overrepresented, but when you do a community prevalence study, gender distribution is equal. BPD usually emerges during adolescence, but we have published a paper, and there are a few other papers saying that borderline personality disorder can present for the first time, can manifest for the first time, even in older ages, 40 to 50 commonly, and a third of our patients at the Spectrum, the organization where I work with, they have late manifestation. We have diagnosed someone with BPD for the first time, even in their 60s and 70s. Sometimes people have risk factors, they don't manifest with BPD, and for the first time when they're retired and they go into nursing home, or when they lose their spouse, they tend to manifest with borderline personality disorder in their 60s or 70s. Now, the etiology of borderline personality disorder is often controversial. The last word has not been said. However, what we now know is that there seems to be a significant heritability factor. Half of the reason why people develop borderline personality disorder is because of the genes that they inherit. Of course, it is not a direct translation. What the genetic vulnerability makes people have a vulnerable emotional system, the amygdala perhaps, and amygdala tends to be hyperreactive and hyperactive, and the control mechanisms from the prefrontal cortex, which tends to modulate the actions of amygdala, tends to be very poor and limited in borderline personality disorder. Very similar to what happens in post-traumatic stress disorder. So the emotional system is very, very active, and it is not adequately regulated by the inhibitory systems, the regulatory mechanisms of the prefrontal lobe. It's also been shown that we all know that people with borderline personality disorder tend to have difficulty in cooperating. And there seems to be a profound incapacity to maintain cooperation due to the anterior insula abnormality in the brain. We know that childhood trauma is a very significant risk factor for borderline personality disorder. However, it is not causally linked. So childhood trauma by itself doesn't cause borderline personality disorder. Uh, Childhood attachment problems are again risk factors. Again, they themselves don't cause a borderline personality disorder in later life. It's a multitude of factors interacting together that seems to result in borderline personality disorder. So biological and psychological factors may be causal, with each person having a unique pathway to developing borderline personality disorder. However, there's a lot of dispute regarding the relative contribution of various factors. We know that BPD is highly stigmatized disorder, and there's lots of discrimination, and is dismissed as just a behavioral problem. And when it comes to suicide rates, 10% of the people with borderline personality disorder tend to die by suicide, which is very similar to the schizophrenia, bipolar disorders, and depression. We also know that the lifespan of a person with BPD is almost 20 years less than average population. This is again a shocking data because nearly two-thirds of them seem to have multiple medical problems because of the poor lifestyle and obesity And also they don't seek help from their medical practitioners for the general health problems. Also, we know that chronic exposure to stress while they're growing up and during their adult years, because of the borderline personality disorder, they tend to develop lots of stress-related physical disorders and psychological disorders. Now, we did a study in Victoria, the state, one of the states in Australia, and we demonstrated that 10% of all suicides for all reasons in the country was for a personality disorder. And when we say personality disorder, it was almost always for borderline personality disorder. So 10% of the suicides for all reasons is for a borderline personality disorder. Then we looked at the age distribution of when people are at very high risk for dying by suicide. Surprisingly, we found that it is the adult years, 25 to 64. That is when 80% of all BPD deaths occurred for suicide. And when you look at less than 18 years, only 5% of the people died. Although under 18 is when there's lots of anxiety about young people self-injuring, self-harming, and expressing suicidal thoughts. But the death by suicide seems to occur in adult populations. We also found that 99% of them, when they died by suicide, they had contacted public mental health services 1 year before. And 88% of them went to public mental health 6 weeks before they died. Quarter of them went to emergency departments. And this is a table which shows that, people are actually contacting health professionals before they die by suicide. So there may be opportunities to intervene. So this is the data. So I told you this is in the community, the risk of death for borderline personality disorder is 10%. However, I looked at the data for our service. So when people are in treatment with us, so usually people when they come to our service, they receive treatment with dialectical behavior therapy, mentalization-based treatment, acceptance and commitment rate in our hands is 0.3%. Compare that with 10%. We also have done a follow-up study and shown that even at follow-up, only the 2% death rate. So what we feel convinced is that when people are receiving or when they receive treatment for borderline personality disorder, and the risk of death by suicide diminishes very significantly. Now we know that borderline personality disorder, there's no medicines. However, psychotherapy is a treatment of choice, and psychotherapy works. There are more than 20 to 25 randomized controlled trials across the globe in various settings that demonstrate that psychotherapy for borderline personality disorder actually works. And the prognosis is not too bad. So most people can achieve a remission at least for a period of time. Recovery is achievable for 60% nearly. By remission, I mean they no longer meet the threshold for diagnosis. By recovery, I mean they're having meaningful relationship and they're actually occupied in gainful employment. Now, the problem is since we have inadequately trained workforce and access to treatment is very limited, and we have no mature models of care, so we do have a problem in creating treatment access for this patient population. I'm not expecting you to read the whole list, but there's a list of all the evidence-based specialist treatments. So DBT, MBT, etc. There's a couple of Australian contributions, the conversation model and acceptance and commitment therapy. Now, all of those treatments, which are all evidence-based, we call them as specialist treatments. All the specialist treatments for BPD are equally effective. When you compare each other, it doesn't really, one doesn't really come out as superior. There are plenty of studies that have been published to show this information. What we also know is that not only the treatments are equally effective, there are more commonalities than differences between these treatments. That's been shown even in my own personal life. When I've done DBT or MBT or ACT or psychodynamic psychotherapy or generalist treatment, They all seem to work equally well. So as opposed to specialist treatments that I've just listed, there's a list of generalist treatments. Generalist treatments such as general psychiatric management, that's called the GPM by John Gunderson. John Gunderson was the one who coined the name borderline personality disorder. And also there is a structured clinical management, which Anthony Bateman came up with. And Anthony Bateman tried to compare MBT with structured clinical management. He was hoping to perhaps demonstrate that MBT is far superior. Surprise, surprise. MBT was as good as structured clinical management, no better. Now, GPM, Good Psychiatric Management, General Psychiatric Management, has been compared with DBT. They both are equally effective. Good clinical care, again a generalist treatment, has been compared with cognitive analytic psychotherapy, equally effective. Supportive psychotherapy has been compared with transference focused psychotherapy, equally effective. So they're all equally effective. And also, even the generalist treatments, they're all equally effective. So, what the summary is that generalist treatments are as effective as specialist treatments. They're all equally effective. There are more commonalities than differences between specialist and generalist treatments and each other. I'll let you digest that fact for a few seconds. So they're all equally effective, nothing much to choose between them. Now, MBT was even followed up for 8 years, comparing with structured clinical management. MBT showed very marginally, it came out really marginally better in terms of functional outcomes. Otherwise, overall benefits were similar, even at follow-up. So there are lots of common factors between all of these treatments. Now there is a group of several clinicians have tried to look at the common factors in all the specialist treatments, in all the generalist treatments, and also a group of international expert opinion was undertaken, and also the national guidelines of Australia, the NHMRC clinical practice guidelines. When you look at all of these things, and you can list a set of common factors. So our guidelines in Australia outlines general principles for treatment that are similar to common factors of specialist and generalist treatments. Uh, a, a researcher in Melbourne went to the extent of trying to compare cognitive analytic psychotherapy, which is a evidence-based treatment for BPD, 16 sessions. He compared that with regular case management, which is a treatment as usual, and also controlled it with befriending. This is a general common man on the street or a woman on the street who were told to just befriend people with borderline personality disorder, not necessarily provide any counseling. In fact, they were deliberately told to avoid talking about any problematic issues. That was set as control, and to see whether a very highly defined psychotherapy such as cognitive psychotherapy would come out as better. What was surprising was that in this study, even befriending came out as equal to cognitive psychotherapy and regular case management. So basically, anything that you can do seems to help as long as it is thoughtful. So when you look at the summary of all these common factors, all the evidence-based treatments that are available to date in the world for borderline personality disorder, these are the essential aspects. First of all, we need to help people with borderline personality disorder to get well from borderline personality disorder. So what we need is psychological work. But it's going to take time. So we need to keep them alive while they're receiving treatment. So we need good crisis intervention plans. We need to help them to improve their physical health and well-being, because remember I told you that there's a 20-year reduction in lifespan and they develop multiple medical problems. So we need to attend to their physical illness. We also need to help them to improve their quality of life, getting jobs and relationships. And we need to educate and support the families and cares, because they are the ones who are working with, helping and working with this patient population 24/7. Okay, so what I've done is that I've looked at all the published guidelines in the world to date, the Scandinavian guidelines, all the European guidelines, the American guidelines, the Australian guidelines, and the South American guidelines, all of them. And also looking at all the evidence-based treatment that have been published. And I've tried to summarize the best practice principles, um, which is there in all of these treatments and all of the guidelines. So this is the list. First of all, we need to be able to establish a clear diagnosis of borderline personality disorder and tease out any co-occurring conditions. We know that the borderline personality disorder is being called as the king of comorbid kingdom because most of the time BPD doesn't present alone on its own. It presents along with other psychiatric disorders and sometimes medical disorders. So we need to tease out the co-occurring disorders and treat them appropriately, uh, and provide good psychoeducation to family and patient. This is all common sense. I'm sure you do, all of you do this already. And in the Australian setting, we are very willing to make a diagnosis from the age of 12, post puberty, because early intervention makes a huge difference. If we don't treat them early, they tend to develop more entrenched patterns of behavior, which becomes more difficult. Of course, if you're treating someone under the age of 18, it needs to be age appropriate. You need to take into consideration the developmental aspects. One of the core principles in the best practice of treatment of BPD is to develop a shared understanding. The clinician develops a shared understanding uh, with the patient of their predicament and also helps the patient make sense of themselves and how they can recover. So that shared understanding is a crucial aspect of the work that needs to be done. Now, also, where possible, where it is available, by all means, refer them to BPD-specific psychological treatments. We need to have a thoughtful management plan for crisis, developing a crisis plan involving the family and carers, and addressing the suicidal and self-injury behaviors. Maintaining focus on recovery, particularly encouraging them to get some sort of a job, and if they're in healthy relationships, helping them to keep the relationships going, and if they're in unhealthy relationships, helping them to overcome and get away from those dysfunctional relationships. When you're looking at psychological work, it needs to be evidence-based, structured. Consistency is the key. Being active, a psychoanalytic kind of an approach where the clinician is very passive and inactive doesn't work with people with BPD. In fact, they get very anxious. They can even dissociate. We need to have clear boundaries and limits, but boundaries have to be compassionate. Limits have to be flexible. The work needs to be informed by trauma, and where necessary, trauma-focused or trauma-sensitive treatments need to be undertaken. We need to have a non-judgmental approach towards these patients because a lot of their actions and behaviors might trigger judgments in us. We need to be validating and empathic, look at pragmatic interventions, and focus on therapeutic relationship. So clinician patient relationship, the therapeutic relationship is one of the key factors for outcome. In fact, the therapeutic relationship contributes to 50% of the outcome. So if we can get along with patients, half the job is done. We need to focus on emotions, our own emotions, and the patient's emotions, because emotions are going to be very rampant when we work with people with borderline personality disorder. Develop a collaborative plan involving family and carers and relevant stakeholders, and also help the person with some skills to manage their painful thoughts, emotions, self-sabotaging behaviors, suicidal self-injury behaviors, and the interpersonal difficulties. Medicines, there's no medicine for borderline personality disorder. Therefore, even if you're using medicines for co-occurring conditions, it needs to be very carefully prescribed and hospitalizations had to be sparingly used. Remember that 25% of the patients with BPD attempt suicide, not self injury, suicide with prescribed medications. 25% of them. So be very careful. Monitor the progress carefully, look after their physical health, and practice self reflection. Because when you're working with people with BPD, we're going to have a lot of judgments, we're going to have lots of emotions, anger, sadness, hopelessness, hopefulness, or rescue fantasies, etc. So practice self reflection. Be become aware of your own thoughts, emotions, and reactions. And mindfulness often helps us to achieve that self reflection. We need to provide a continuity of care and keep an eye on the quality of life and keep supporting family and carers. So that's really the summary of the treatment principles. Now, when you look at good psychiatric management, the GPM, general psychiatric management, which was the evidence-based approach developed by John Gunderson, the guru himself, the GPM principles really the same principles that I've outlined. Offer psychoeducation, be active, not reactive, be thoughtful. The relationship is real and professional. Accountability on the part of us and on the part of the patient. Focus on life outside the treatment, recovery focused, being flexible and pragmatic. These principles are no different to the common factors principle that I just outlined. Again, I'm repeating myself, but it's worthwhile repeating. Therapeutic relationship is the key ingredient of effective treatment for borderline personality disorder. Contributes to 50% of the outcome. So this is my way of trying to um, give you an example of a metaphor for the entire treatment of borderline personality disorder. We said one of the basic pathology in borderline personality disorder is the emotional system. The amygdala is overactive, hyperactive, and the prefrontal cortex, which is supposed to control the emotions, the amygdala, that's very limited in its activity. So we have a double whammy situation where the emotions are running wild and the control mechanisms are very poor. Now, if you compare the emotional system of a person with BPD to a car, I don't mean any disrespect to patients, then the person with BPD is driving a car with hypersensitive accelerators, emotions, and very poor brakes, cortex. You can imagine if the person is driving such a car, they're not going to be able to drive properly. The driving is going to be erratic. They're going to go through red lights. But however, for the onlooker, they are going to blame the driver, not the car, because they can only see the driver and they think that the driver is driving poorly. But the point here is that if we were people who don't have borderline personality disorder, if we were given that sort of an emotional system, probably we would have done much worse job. So what is the treatment? Treatment is for us to be sitting in that car and teaching the patient how to drive that car, which has got very, very sensitive accelerators and poor brakes. And we need to share the risk along with the person, you know, and the demand is for the clinician to be an empathic driving instructor. Of course, the driving instructor has their dual control mechanisms. They can put the brakes if need be, but that is compared to medicines and hospitalizations. But if you keep using the hospitalizations and medicines, it's like locking up that car in a garage, in a service station all the time, but not really teaching the person how to drive the car. Of course, we need to teach the person not to pick up the wrong kind of passengers and also not to use jet fuel, that is the drugs. So, so these principles that I outlined are common sense principles. I'm sure I've not taught you anything new there, but all these principles, although are they very simple, they can be very hard to apply in practice. The reason why it is hard to apply in practice is when you work with people with borderline personality disorder, our judgments come up automatically. Our emotions come up automatically, the counter-transferences. That's inevitable. If you experience reactions, counter-transference, Don't be hard on yourself. That's a normal thing. Anyone who works with people with BPD are going to experience those emotions. If you know how to avoid being harmful, you can surprisingly be very helpful. This is a point I made already. Therapists need to reflect on their own emotional reactions, the counter-transfer, which is again a very key aspect. So, in summary, having BPD is not the person's own fault. It is a disorder of the brain and the mind. So that's one of the important statements that we have made in our national guidelines. That's incredibly validating to people with borderline personality disorder. However, these patients can be difficult to treat. Let's not mince words, but it is the illness that produces the behavior, not the person. Now I'll try and see whether I can play this video. Uh, how many? Um, oh, okay, I'll do one thing. I'll come back and play the video a little later. Hopefully, it'll work. Now, I said that people with borderline personality disorder have other co-occurring disorders. So this is a guide to decide when do you prioritize treatment of BPD, when do you prioritize treatment of other disorders before you treat BPD. Generally, if there's a mood disorder, clinical depression, bipolar disorders, bulimia nervosa, social phobia, anxiety disorders, narcissism, then you prioritize treatment of borderline personality disorder. If there is PTSD, ADHD, ASD, panic disorders, then the guideline is to stabilize those disorders before you start BPD treatments. However, we know that complex PTSD and BPD can be treated together. Again, ADHD and BPD can be treated together. If there is a severe OCD, it makes sense to treat OCD first. Of course, if there is severe substance use disorder, bipolar mania, or severe anorexia, you need to treat that disorder before you start treating BPD. We have tried to develop a core competency framework using the same principles that I outlined. I'm not going to go through this. So looking at the common factors in all the treatments, we have come up with 10 competencies. So we have developed a core competency framework and we teach clinicians these 10 competencies, and we have developed a whole training program. It's a national level training program, training all clinicians in those 10 competencies. Okay, now let's see. I said that there are no medicines for borderline personality disorder, but is there a pill? There's no medicine which is licensed or indicated for treatment of BPD. And quarter of the patients attempt suicide, I told you. ECT is not helpful. TMS, it's not sure, but so far the evidence is lackluster. So there's some limited evidence that TMS may be helpful to treat the underlying depression. Again, it is touch and go. I did a study looking at the prescription patterns in Victoria, this day in Australia. Half of the patients with BPD were prescribed 3 to 5 medications simultaneously. We're talking about psychotropic medications, although there's no medicine which works for BPD. People are desperate to help patients and they're trying to prescribe medications. But the chances of overdose and chances of obesity, metabolic syndromes are very real. The global consensus is that psychotropic medications tend to reduce probably 20% of the intensity of symptoms. Is it a placebo reaction? We don't know. So when we analyze all the data which is available, see quetiapine, there are a couple of studies saying that it can be used for crisis management in a low dosage, 25 to 150 milligrams, somewhat helpful. Maybe side effects, we don't know, or the anxiolytic effect. But in the crisis for short periods of time, 1 to 2 weeks, we can use quetiapine. In the long term, it doesn't help. Lamotrigine and topiramate, there is some couple of good randomized control trials. I tend to use lamotrigine in my practice because a lot of people have depressive symptoms even if it is not a depression. And also, it helps in anger discontrol. And there's some evidence that it helps with mood instability. And lamotrigine is a drug which doesn't cause weight gain. It is a much more clean drug, especially if you're prescribing women. Of course, you need to take care of the teratogenicity aspect of it and advise women not to conceive. Quetiapine I also use for crisis management, and I don't use other drugs. Aripiprazole, there is low doses, there is some evidence. Fluvoxamine, there is some very limited evidence. Fluoxetine and olanzapine I used to use before. Now there is really no evidence. Omega-3 fatty acid, there's one particular preparation which is available in Australia called the Ultra Clean. I don't know if it is available in India, which has got the EPA 1200 units and DHA 800 units. And that combination seems to be somewhat helpful. 4 capsules a day, again, harmless, even in overdose, it is safe. I tend to prescribe this drug. I tend to prescribe only if patients are very demanding and uh, very taken by medicines. So really the overall it's lackluster evidence for medicines. Future treatment options, if we can come up with an amygdala modulating agent, it could be helpful. Maybe a different type of TMS, a deep brain stimulation. Now are the days of artificial intelligence assisted psychotherapy or psychedelics. We are actually just commencing a study looking at MDMA assisted psychotherapy. We are hoping that that may be somewhat helpful for people with borderline personality disorder. EMDR, not sure if it has a role. It has a role for BPD, but it can help if there is complex PTSD which co-occurs with BPD, but in the hands of experienced EMDR experts. Now, EMDR, now complex PTSD prevalence in BPD is 50%. So half of the people with BPD will also have a co-occurring complex PTSD as a diagnosis. So if they do have, by all means, try EMDR only if you're experienced. So role in BPD for psychedelics is not yet established. It's still in the experimental phase. So effective psychotherapy treatments for BPD can be provided by psychiatrists and mental health clinicians who lack specific training in psychotherapists, because if you can learn these core competencies, those common factors, you can be good enough psychotherapists providing psychological treatment for BPD, even if you're not trained in one of those evidence-based treatments. We have published a paper to that effect. So my take is that psychotherapy for BPD is not rocket science. You can learn the core principles and we can all make a difference together. This is John Gunderson, who is the father of borderline personality disorder, who makes the statements that most clinicians can effectively treat most people with borderline personality disorder. So this is John Gunderson again trying to say that you don't need to be a specialist or a selflessly devoted clinician to be good enough. You need to be warm, reliable, interested, and unintimidated. And you need to know, you need the basic knowledge about case management. Again, John Gunderson making a point that being excessively fearful of making mistakes with borderline personality, that is one of the anxieties clinicians have, that can actually rob both you and the patient of the essential humanizing process that's so important in the treatment of BPD. Again, John Gunderson taught that we need to lean into difficult conversations with borderline personality disorder, not avoid those conversations. We should not treat people with BPD as being too fragile. We need to assume self-agency and competence and work with them. Few papers about outcome and then I'll stop. So this is the long-term study by Zanini. It went on for 24 years. And this is a 10-year collaborative longitudinal study in US. Both the studies showed that outcome for borderline personality disorder is not too bad. So it showed that most people can achieve symptomatic remission for periods of time. So long-term studies show that about 99% of the patients, almost everybody can achieve at least a 2-year remission. Nearly 78% of them can achieve a remission for a period of 8 years. So these are all good numbers. And self-injury and suicide attempts keeps going down over a period of time if you start working with people with BPD. So that's the same experience for a spectrum. So if you really work with people with borderline personality disorder, they don't seem to die. So this is a 12-month outcome data of spectrum reduction in self-harm suicide attempts. This is an 18-month follow-up study, again showing reduction in symptoms and suicide and self-harm behaviors. We did a intensive group treatment, 8 hours of group treatment a week for 10 weeks. That's such a, in a group setting, even there we found that suicide and self-harm behaviors improved. A recent meta-analysis shows that at least 50% of the patients respond to a year of psychological treatments. It's not a bad outcome. So the summary is that take-home message, any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to people with borderline personality disorder, says Mary Zinnerini, one of the most eminent researchers in the field of BPD. This is Joe Paris, again, another Canadian expert on BPD, who says, as long as you don't judge, as long as you try to validate the valid, as long as you can tolerate emotions, yours and theirs, and teach them skills to improve the quality of life, you can contribute to their recovery journey. Thank you. I hope I've tried to convince you that you can, all of you are probably already treating BPD patients quite well. Just persist, be consistent, you will get good outcomes. Thank you.
Thank you, Dr. Satya. Like it was quite an enriching last few minutes to hear about BPD, and thanks for bringing different layers and a kind of holistic approach to understand the symptoms and how to manage our clients with BPD. So now we open this forum for discussion. We do have a lot of questions that have come in through email. But before I jump in, anyone, any inputs, anything that you would like to add on or ask, Dr. Satya? I guess I'll initiate with the questions that we already have, and I guess like by then the participants will be able to pitch in as well. So one of the questions that we have received is like, what is your experience with BPD patients, pregnancy, and motherhood?
Yep. The prevalence of postnatal depression is seems to be higher. Number one. Number two, in the Australian setting, in the Western setting, a cohort of people with borderline personality disorder who have had severe attachment disorders, who are lonely, tend to conceive, even if they're not in a relationship. They have a one-night stand and just conceive just for the sake of conceiving, because they feel that they can form the attachment to the infant, and in some situations that has actually been helpful, but in most of the other situations it can be problematic. So that's another observation. Capacity to parent, again, is a hugely controversial issue. Uh, in the Australian setting, we have a child protection system where if the government thinks that the child is not safe, and they can actually take away the custody and probably give the custody to someone else. Now, 1 in 6 parents with a diagnosis of borderline personality disorder seem to have child custody issues. Very significant number. So if the attachment disorder is not addressed, and if they have a child, then transgenerational patterns of borderline personality disorder could develop, because as such, the child is going to be genetically predisposed, at least 50% of the contribution. And if you add the childhood attachment difficulties, if the mother of the borderline personality disorder can't really provide attachment, and again, it causes a problem. And men with borderline personality disorder tend to develop a lot of jealousy when their partners conceive and become pregnant, have children. So they because they need that attachment. Their attachment needs are so high, they can't tolerate another being sharing that emotional need. Those are some of my observations.
Right. Thank you, Dr. Satya. So, like, I'll just want to just ask something about the fathers, because in our Indian population, majorly we end up seeing mothers with pre-existing BPD. But what is the turnover of fathers coming to your service during their postpartum period?
You mean the fathers with borderline personality
Yes,
disorder?
yes.
So not very high. We don't see many of them unless they are already in treatment with us. See, but the problem we have is that although in the community the prevalence of borderline personality disorders is the same between men and women, uh, and when it comes to clinics, at the referrals that is 70-30, 70% is for women, 30% is for men. But in treatment, we have probably about 3 to 4% of men. So they don't come for treatments often. We don't know whether it is because our treatments are not tailored to men, because all the treatments that we have, they were all developed for women. And all the evidence that we have today, as of today, is 95% of the evidence is for women, not for men. So we are assuming that the same treatments would work for men too. We don't know. Also, most of the clinics are open between 9 to 5 during working hours, when men are often engaged in gainful employment. Also, if you look at the workforce, at least in the Western systems, it's predominantly female workforce who take up this work. We don't know whether there is a gender issue there. So there are lots of challenges in trying to treat men as such. Then men with borderline personality disorder, where their partners are conceived, that's a whole different ballgame.
Right. Thank you, Dr. Satya. Like, another thing that was cropping, because we are talking about males, right? So, do you see the manifestation of symptomology in males different from females in your clinical practice?
Look, we don't know, because we have done a study, we actually published, but in that study we didn't really see much of a difference between men and women in terms of symptoms. However, men tend to uh, land up in drug and alcohol settings more often. Men also tend to land up in prison systems, legal systems, because of the anger and aggression. Anger discontrol is one of the symptoms. Emotion discontrol, impulsivity, and anger, uh, that probably lands men in more trouble than women. So those problems are much more severe. But when it comes to fear of abandonment, emotional dynamics, emotion dysregulation, identity dysregulation, impulsivity, micropsychotic symptoms, dissociative symptoms, chronic emptiness, they're all very similar.
Right. Thank you so much. So we do have a few questions in our chat box. So let's make it more interactive. So Mr. Shant, would you like to take up your question?
We would appreciate if y'all could switch on your videos and ask the questions. The rest of the section is mainly committed to having this interaction.
Okay, I'll go ahead.
Sure, Dr. Lata. Yeah.
Yeah. It was a great presentation with very comprehensively covering all the areas. The question I wanted to ask was, often we come across relatives of BPD clients, and BPD clients are not so open to therapy always. And either the spouse or the parent or a sibling who is in distress because of the client's behavior lands up with us. Do you have any guidelines about this, how it can be handled when the patient is not willing to come for therapy?
Uh, if the patients don't come at all, it's a problem, obviously. So if they do come even once, you would want to not go for psychotherapy as such. Just starting to build a relationship, therapeutic relationship of some sort. Just getting to know them, just hearing their version of the story often helps. If only the families turn up, it becomes a problem because if they already have challenges in their relationships with family members, they're not going to take the advice from family members to go and seek therapy. The inherent problem there is that they are the people with BPD often, not always, often tend to understand their disorder from their childhood experiences and trauma experiences. And they have if we give them a diagnosis of borderline personality disorder, and if you ask them to go for treatment, we are actually telling them that you have a problem. You are the problem. You have a personality disorder. So, see, whatever we say, the name personality disorder is understood by people as there's a problem in my character. It's a character flaw. I am flawed. I'm behaving badly. That's what they're saying. So my parents and siblings are saying that I'm behaving badly, so I should go for counseling and go to see a psychologist, a psychiatrist, or a nurse to get some treatment, so fix myself. You can see why that would be very unattractive for people. So at a global level, once the awareness is more, people start seeking help. In the Western setting, that has improved a lot. They seek. In the meanwhile, though, if only the family members turn up, what we tend to do is we put them through a lot of psychoeducation. We teach family members how to actually work with people with borderline personality disorder, how to relate to them. All the principles of care that we have discussed, many of them we can teach the family members. So they can actually start changing their behaviors. And they could, we have done this a few times, where we have done this work. We've asked the family to come several times. We have taught them how to interact with their loved ones. Then they've said, the gone and told the person that, look, we went for counseling. It helped us to understand what's happening in the family. So maybe you also might want to go and try because it helped me to. So you're not. See, I think the blame needs to be taken away. Once the blame is taken away, people may be a bit more willing to start working with us.
Thank you so much. Thank you.
So I'll quickly ask a question on behalf of Vishant because he seems to be traveling. So his question is that he has come across the clients start to show hopelessness towards psychotherapeutic treatments, and even in therapists that treatment is not working. So you wonder if it's common phenomena and how can a therapist deal with this?
Purnima, let me get the question right. So yes, the question is, the therapist is experiencing hopelessness.
And even the client is experiencing hopelessness towards psychotherapeutic treatment. So how that can be worked out?
So probably what's happening, I'm just heralding a guess here. What is probably happening is that the patient is not improving. The person is not getting better, or at least perceiving that the person is not getting better. And the person is feeling hopeless, and the therapist is having a counter-transference of hopelessness again, right? And they both are caught in that hopelessness dynamic. So the demand for the therapist is to hold hope. Given the literature, given the science that we have, because we know that people with borderline personality disorder can get well. We know psychological treatments tend to work for most people. So the therapist needs to hold hope. I'll give you an example. A few years ago, we conducted a conference. We put a group of recovered people with borderline personality disorder on the stage, on a panel. So we posed them one question. What do you think is the best thing clinicians can do for you when you're really not improving and progressing? You know what they told us? They said, please don't give up hope on us because we find it hard to hold hope. When you give up hope, that's when we also think that there's no hope for us. So you holding hope sort of gives us something to hang on to. Even in the moment, even if I don't agree with you. Right. So my suggestion is that in that situation, if I have experienced that hopelessness, say again, it needs to be seen as a counter-transference phenomena. So if there are times when I felt extremely hopeless about patients, then I go and seek some supervision and process my own emotions and feelings. And then I come back and start working, things seems to get better. I'll give you one example. There was one client I'd worked with for about 3 years. She was a lovely, lovely woman. She actually got really well, and I was, thinking that at some stage I need to start talking about discharge. So it was around that sort of a stage. Now, for some reason, there was a crisis, and she started talking about suicide. And she's done that numerous times. There's nothing new. For some reason, I became very anxious about a suicide risk. And as I became more and more anxious over a period of time, the patient actually became more and more worse. I tried all sorts of things, nothing worked. I took a second opinion, third opinion. I hospitalized the patient. I put her on medicines. Nothing worked. And so I was getting more and more hopeless and anxious. So I went for supervision. Then the supervisor said that, why are you feeling so anxious? I mean, I've never seen you this anxious before. And my supervisor couldn't really figure out why this was happening. So one fine day, I actually caught up with the patient again. I said, tell me what's happening between us. What do you think is really happening? And why are you actually deteriorating so much? Of course, I'd asked that question before, but in this situation, it was a very different conversation. You know what the patient told me? She said, look, seeing you so worked up and anxious actually made me feel very anxious. I thought there's no hope for me. Maybe I'm actually suicidal. So our own emotions can actually trigger things for patients.
Thank you, Dr. Sathya. So there's another question from Arundhati, and she's asking about if there is any role of mood stabilizers such as oxcarbamazepine and lithium to control the symptoms of mood swings and impulsivity in patients with BPD. And could you please share your experience?
So carbamazepine doesn't work. There's no evidence at all, and it doesn't work even in practice. And sodium alprovate I would not touch at all, because it causes heterogeneity, obesity, plus it can also trigger polycystic ovarian syndrome. Another observation, quarter of the patients with borderline personality disorder have polycystic ovarian syndrome. So be very careful, don't prescribe those two drugs. If you really want to prescribe, go for lamotrigine. I know it's a bit expensive, or topiramate. I would not suggest any other psychotropic medicines other than, of course, quetiapine or aripiprazole for crisis management. If patients demand, prescribe that fish oil I was talking to you about.
Right. Thank you, sir. Amita?
Yeah, thank you for the presentation, Dr. Sathya. I had a question with regard to one of the slides, which was the guidelines for MX of coexisting disorders, where you talked about the recommendation, the coexisting disorder, and the rationale behind it. So I'm a little confused here because the recommendation is prioritizing BPD treatment, but BPD treatment per se, in terms of medications, subsequent slides, you mentioned that there aren't many.
When you say treatment, I mean psychotherapy. Whenever
Sorry?
I use the word treatment for BPD, I'm talking about psychotherapy.
Okay. Okay.
Not talking about
So in
medicines.
terms of, so what my question is basically that when when clients come to us, I'm a practicing psychotherapist, they come with the coexisting, we see more of the coexisting disorders. So there's anxiety or panic attack, or there could be eating disorders and all the rest of it, social anxiety, all of it. Uh, so my question is, do we look at working at the beginning with the presenting issue and then look for evidence for BPD? And then what would be the best kind of diagnostic model? Because I've also encountered some misdiagnosis in BPD cases.
Look, okay, as a blanket solution, if someone is manic, in mania, or someone is experiencing psychotic disorder, or as a severe eating disorder, mainly anorexia nervosa, those are or when someone is using drugs so much that they can't even come to your session to sit down and have a chat. In those situations, you can't really do psychological work for BPD. You have to prioritize other treatments, the treatment of other conditions first. But in most other situations, it is best if you could treat BPD and also treat the other co-occurring disorders. Okay, so that's the general principle is treat both. Don't neglect the treatment of BPD, because if you don't treat BPD, it offers treatment resistance to other co-occurring disorders. Classic example is depression. I'm talking about not the depressive symptoms, which are ubiquitous in borderline personality disorder. I'm talking about biological clinical depressions. When those biological clinical depressions co-occur with BPD, there are really good randomized controlled trials to show if you treat only borderline personality disorder, the co-occurring depression goes into remission even if you don't treat depression. Now, if you, let's say that take a group of people with BPD and depression. Okay, let's divide them into 3 groups. For one group of people with BPD and depression, let's only give BPD psychotherapy. Both BPD and psychotherapy, BPD and depression goes into remission. To the next group of BPD and depression, let's give only antidepressants. Neither depression nor BPD goes into remission. Okay, so let's take another group, same BPD and depression, treat with antidepressants as well as BPD treatment, psychological treatment. Again, both conditions go into remission. So with mood disorders, it's quite clear. And unless you prioritize treatment of BPD, the mood disorders don't remit. It offers treatment resistance. Same thing for all the anxiety disorders. The exceptions are severe OCD, severe anorexia nervosa, substance use disorders, psychotic disorders, and mania.
The following follow-up question was the diagnostic of BPD itself. They're quite, what would be a good understanding of the diagnostic? Because there are some who come with flawed diagnosis.
Yeah. Look, so there are lots of good screening instruments available now. So just the Zenerini rating scale or McLean rating scales, they're more than enough, really. And those scales can be done in your clinic. When the patients are waiting, it takes about 10 minutes. And they are generally indicative of borderline personality disorder. And you can go through the 9 criteria. And if people meet 5 out of 9, they generally they have BPD. Even if they have 4, you would want to start treating them. And sometimes, let's take a person with very severe childhood trauma. Okay, very severe neglect, very severe eating, attachment disorder as a child. If they've had that sort of a condition, what they can, during the adult years, when they have a BPD diagnosis, they could also have symptoms that look like autism spectrum disorder. It looks like, but if you really do the proper autism test, it doesn't measure up. That's because the attachment disorder is so severe and the trauma is so severe, they exhibit some of the symptoms of ASD, which can be misunderstood. Depression is classic. People with BPD have miserable, painful lives. They have lots of secondary depression. It's not a primary clinical depression most often. But even if there's a primary clinical depression, that's not going to respond to ECT or even medicines as well as an independent depression would. You have to treat BPD, otherwise it doesn't respond. But the sensible thing to do will be to treat both the conditions together.
Right. I'll come back to you, Vaidehi, because it's just an extension what Shere Banu is asking, that how would you like to draw the line between to understand the criteria of BPAD and BPD?
I mean, bipolar affective disorder.
Yes.
Those are very different conditions, completely different conditions. In bipolar affective disorder, you see very distinct, clear manic episodes and depressive episodes. And manic episodes, you will by definition last at least for a few days continuously, and often for weeks and months. And depressive episodes often last for several weeks and several months. Even if you're looking at a rapid cycling bipolar affective disorder, that can be very clearly differentiated from BPD. In BPD, the mood fluctuations happen from minute to minute, hour to hour, day to day. And it is usually in the context of interpersonal triggers, real or perceived. In rapid cycling affective disorder, there's no trigger. You don't need to have a trigger because it's endogenously driven. So it's a very different flavor. Also, in borderline personality disorder, you're going to have the fear of abandonment, emotional dynamic, identity dysregulation. You're going to have impulsivity, chronic emptiness. None of those things are going to be there in bipolar affective disorder. These are very different disorders.
Right. Thank you, Dr. Vaidehi. Over to you.
Yes, hello sir. Thank you for your valuable insight. So I just came across this term favorite person like in BPD, and I would want to ask you, can you shed a little light on it? And when the person with BPD shows that attachment to the therapist also as a FP, how do we handle that? How do we deal with it?
Look, so that's what you're talking about is transference, right? So patients developing strong emotional attachments towards therapists. Now, see, that's the tricky bit that as a clinician one needs to handle. One is, first of all, people with borderline personality disorder are often deprived of emotional connections, emotional attachment, right? Their attachment bucket, so to say, is nearly empty. When they come to you and you're going to sit down with them, offer one-to-one, you're validating, you're empathic, you're nice to them, you're understanding, you're respectful, non-judgmental, you're actually being a very nice person. And that is and you're going to see them every hour, 1 hour a week at least. So they are bound to form attachment with you. Now, what they're trying to do is they're trying to fill their attachment bucket, which has been nearly empty, because they're desperate to fill the bucket. Now, that relationship, patients might find it hard to keep the boundaries of the relationship. In worse situations, it can even lead to stalking or patients falling in love with the therapist. Very common. However, the therapist, if they are very clearly aware of this and they can set limits and boundaries, right? And if, let's say, the patient falls in love so strongly with the therapist that can't be handled at all, then the therapist probably need to talk to the consult a senior colleague or a supervisor, then hand over the patient to somebody else in some situations, if that can't be sorted out at all. Because if it is especially romantic relation, then it can lead to other complications. The problem arises when the therapist doesn't realize it. The common mistake happens, young woman with borderline personality disorder, a middle-aged male therapist who has problems in relationships themselves, marital relationships, that's an ideal recipe for boundary transgression. Because the relationship between the patient and the therapist Because we are bored. See, what we say that the therapy relationship between patient and therapist is the real relationship. You need to be honest. You need to be open. You need to be little bit. You need to be able to share yourself to the extent it is helpful to the patient. But all these ingredients they're just on the edge. If that is not handled properly, it can lead to a real one-to-one human relationship. So that is the boundary which we need to keep all the time. If the patients fall in love with us, we can't get angry with them. You need to be compassionate, but keep the boundaries. It's our job to keep the limits and the boundaries all the time. But to make that happen, we need to be able to process our own emotions, thoughts. Remember, I was talking about practice self-reflection. We need to practice self-reflection of our emotions, thoughts are going to come up inevitably when you're working with BPD patients. But you need to realize that those emotions are triggered in that context. And it is not it is not a real romantic relationship. It will have all the feel of a romantic relationship, for example. Or anger. Some patients, in some therapies, you experience intense anger because you feel manipulated. You feel, uh, um, the patients are trying to can have an impression. You can develop an impression that they're exploiting you, they're manipulating you, etc. Again, those are counter-transference feelings that you need to become aware and manage it. We have a rule that anyone who works with people with borderline personality disorder must have some degree of supervision. If you can't afford supervision, talk to a friendly colleague. It's basically to process emotions, thoughts, so that you don't take it to the next session. And even if you can't hold a full session, even if you're being able to be therapeutic in your interactions, that's good enough. Sometimes patients can just tolerate a 5-minute phone call. That's okay. For the next few months, just a 5-minute phone call may be all right. Slowly, it can build into more time. You need to keep an eye on the therapeutic relationship because that's really a key part of the work. We need to have a healthy therapeutic relationship which is warm, and friendly, but boundaried, but real. You can see how it is a very delicate, a tightrope walk.
So,
Purnima, can I ask something in relation to that?
yes, I was just about to take up
So-
one question, then I'll.
So-
So, in just an extension to Dr. Sathya, what you were talking about, there are times when clients end up asking for more frequent sessions, like probably related to transference or other reasons. So, or in terms of prices. So, how do you draw those boundaries?
Look, again, it's one needs to try and understand if the patient is asking for more sessions to seek more attachment, or actually they want to do more work, or they are indeed going through some major crisis, they need a bit more time. So those are all very different situations. There are times when I've seen patients, 2 or 3 times a week for a few weeks because they were going through some extraordinary problems. That makes sense. But there are also times where I know that it's a regular work happening and the patients are enjoying the work so much and I can see the transference happening and then they demand for more time. Or then they start expressing risk. They talk about suicidal behavior, etc. But you can make out that it is not actually a genuine suicidal behavior. It's more interpersonally driven. In those situations, you might want to hold limits and boundaries because there you don't want to create a situation of excessive dependency on you. See, some amount of healthy dependency is very beneficial. In fact, I would think that see in the Western world, which is a very individualistic society, they tend to frown upon dependency. Whereas I'm an Indian, I know in India dependency is a given. It's normal. It's culturally appropriate and healthy. And human beings being dependent upon one another is actually beneficial. That's what now the newer research is showing. So It's okay for people to be dependent, but in a healthy manner. So you need to differentiate between a healthy dependency and unhealthy dependency.
Right. Thank you, sir. Ankita.
Thanks, Purnima. So just continuing on the line of that thought when you're talking about boundaries and attachment, and pretty similar to what Purnima was talking, I was wondering because recently with my clients, I've started seeing that they've started lingering at the end of the session. That, even if you tell them the time is up, you will see them not leaving and they'll keep lingering. And if you ask them, do you have something to say? They'll give you a blank look, but they don't want to leave the room.
Yeah.
I want your comments on that.
Okay, a few things could be happening. It's a very common phenomenon. Also, they might, if they think that you're going to finish, they might actually start talking about the most important thing towards the end. They would not have spoken about that at all. Finally, they say, okay, yesterday I was sexually assaulted. This is at the 55th minute. So one is that patients experience fear of abandonment. So that kicks in as the end of the session. That's a common phenomenon for a lot of people. So one, if it is fear of abandonment, it's actually a symptom of borderline personality disorder. We can't really punish them for that. At the same time, you can't extend the time because you have to see the next patient. So that's one phenomenon to be aware. Second is some patients have the habit of bringing, because they are hesitant to talk about something very painful at the beginning. Towards the end, they gather courage and talk about it. Some people really they don't really respect your time and they just want to extend it. There's all sorts of people, right? Now, if that happens, you might want to bring it up next session. You might want to bring it up and say something like this, like saying that, let's say, patient June. Hey, June, I want to talk to you about something. Look, last session, you wanted to talk more. You wanted to bring up things, or you spoke about suicide things. It was almost time for me to finish. Um, it feels awful for me because it is not fair that I can't give you a decent hearing, and we can't really do the work because time is up. I'm put in this dilemma of uh, wanting to extend and give you the time, and also wanting to respect the next appointment. And I don't know. I don't have a solution here because I have to see the next patient. And if the next patient gets delayed, it's a problem. My clinic has to close at some time. So what shall we do? Because it's not your problem. It is you need to share the dilemma. In MBT, it is enshrined, sharing the dilemma. And both of you have to mentalize. She has to mentalize your problems as much as you want to mentalize her problems. You want to mentalize saying that, look, this I've seen in my practice, I've seen people who have attachment difficulties like yourself tend to find it very hard. Do you experience this distress or psychological difficulties just towards the end of the session? If so, I'm so sorry for that is still happening to you. Let's hope that over a period of time we can work on it. Be empathic, be validating. You don't need to get upset. But what shall we do? I can't really go beyond 60 minutes. What shall we do?
Those kind of cases, like the two options that you said are happening. The third one that happened today was in lingering. At the 50th minute, the patient was like, oh, also, I forgot to tell you that the option that you gave, the first thing. So I said, okay, I'm noting it down. I will address it the next time. And our time is over. Thank you.
Yeah.
And then also the patient was lingering. So I'm like, do you have something to say? No. And then just kept looking at me and smiling.
It's fear
So
of
I'm like,
abandonment.
okay, what's going on now?
Look, also you could say that, okay, write it down and send me a letter or send me an email if that is your practice. So, but you have to keep the boundary.
So if they're not getting up and they're just in the chair, frozen, but not willing to leave the room, is that a attachment issue? Is that a you feel safe, I don't want to leave this room issue?
Be any of them, any one of them. And if it happens, you have to address it in the next session because you can't go on like this. So ask the what should we do? If that happens next time, you're not moving out of the room. I would feel awful to get up and gently get you to not push you away, but carry your hand. But what should we do? Because it's a problem she needs to address. It's
Yeah.
her difficulty. And you can coach, you can teach, but that's the problem. Next session, that becomes the session. Also, you ask, has this happened to you elsewhere? Does it happen to you with your close friends? Do you find it hard to live in them, or when you go out for dinners with your friends or partner? Does it have with your partner? I mean, it's not. I don't think it will be idiosyncratic behavior only in this situation. Probably this person experienced this in so many places, and this is a manifestation in your clinic. Then that can become the focus of therapy for a while. So then what happens is that you are actually seeing this. See, the invitation for you is to see this in the context of her illness. So it is the behavior. Remember, we said some of the behaviors are problematic, difficult, but it's the illness that produces the behavior, not the person. Not to punish the person, but to address the illness. But get the person to take charge to address the illness, because no one else can do it. And see, a lot of this is a principle that can be used in very many situations. So patients also tie your hands and come and tell you that I'm suicidal, I'm going to do this, but you can't call my mother, you can't call my father. Ask them, what should I do? I don't want to lose my license, but pragmatic, practical. I'm a therapist, I have to work, but I don't want to be sued. But I don't want you, before you say that, first say that I don't want you to die, or it'll be very sad if you died. But if you tell me something and don't let me do something, what should I do? What would you do in that situation? What would your friends do? Now, getting the person to take control, accountability. So many of the situations where you are put in a very awkward, difficult situation, it is for both of you to together solve the problem. It is not just for you to solve the problem, because you can't. And then if you don't share the problem with the patient and find a solution, then you're going to experience more and more annoyance, more and more anger, and your judgments are going to come up that she is manipulative. So can you see, you need to address it then and there. Remember, one of the principles John Gunderson says, be very willing to have difficult conversations. Lean into difficult conversations. Don't treat them as fragile.
But if the answer is I don't know, so there's a freeze in the conversation.
I also don't know. What shall we do? We both don't know. Let's sit on it. Shall we just sit for 30 seconds and think? Because see, patients will often put it on you to solve the problems and find the solutions. It's not up to you to find the solution. It's together, us. We both are going to together do it. Of course, see, there are going to be times when they're really so emotionally charged, then they just want some solutions, pragmatic solutions. So that's one of the principles. Sometimes you have to take a very practical approach. You have to judge the situation. but as a rule, because you could say that, look, I can come up with a solution for this, but they're going to be my solutions. We want you to develop the ability to develop solutions yourself, because I'm not going to be there in your life forever. You're going to come to me, you're coming to me to help you and develop that skill to find solutions. What good is it if I keep giving you the solutions? But once in a while, when someone is so distressed, you might give the solutions. But noting that, look, I know you're not in a position to really discuss and come up with a solution. This is my solution, but it's going to be really not that great because it is just my solution. And in the way I think, it's only half-cooked in that sense, but maybe it's good enough for the time being. When you become more competent, when you're less emotionally charged, think about what the solution could be. Next session, we can talk about a solution together. It's always shared, developing that shared understanding. And in fact, if you take those sort of approach, therapy with BPD patients becomes very enjoyable, because you're really not going to take all the stress. Otherwise, what happens is that we become very stressed. It triggers our emotions. Then we don't want to take on more BPD patients. So in my practice, last 15 years, I have only treated BPD patients, both in my private and public. Very happy. I would not want to treat other conditions because these patients are actually they get better, they're grateful. And once you get the knack of working with them, and when you don't take on all their problems onto yourself, it becomes easy.
Right, so just in between, there was a phenomena that you had named, like when patient doesn't leave. So is there a specific name to that phenomena, sir?
Sorry, what is the phenomenon?
So Shilpa is asking, so there was a phenomena that you had mentioned that when patient doesn't leave. So is there a...
Fear of abandonment.
Okay.
Fear of abandonment. See, fear of abandonment is one of the diagnostic criteria. So patients with borderline personality disorder perceive that people who care for them in their lives, people who, with whom they have some sort of a relationship. I'm not talking about romantic relationship at all. Also the relationship, they fear that they're going to reject them, they're going to leave them. It can be a real rejection or a perceived rejection. So as a consequence of that, they develop a fear, the constant fear of abandonment. That's a well-known phenomenon in borderline personality disorder. People with fear of abandonment, emotional dynamics, almost always have had some attachment difficulties growing up. So that's where so that gets played out in the context of not leaving the session, towards the end of the session becoming more worked up, or when the therapist goes on leave, right? They almost always go into crisis. Even if you prepare them very well, they go into crisis by when you come back, you have to clean up a lot, and it's a sort of a punishment to you for leaving them and going away. So, but it's really a fear of abandonment for them. They're actually not trying to punish you.
Right, sir. So before we move to Apurva, so I also wanted to remind you that we also need to play the video that you wanted to show us. So should we do it after we take up 3 questions?
Yeah, we can probably, but see, that video actually talks about the validation. But happy to take questions before I show the video.
Sure. Okay.
Thank you so much, Dr. Sathya, for this talk. I quite agree with what you said. I just had a couple of thoughts, actually. I do agree with what you said at the beginning of the talk regarding how most therapies have similarities. Just like how Lambert, Norcross expressed that decades ago, and they're all effective. And but I do feel that the language of each therapy is quite different. And ultimately, I feel like it's the fit between the language of the therapist and the fit between and the language of the client. I think from today's talk, I think what we're also sort of getting the sense of how to get them out of the diagnosis, such as reducing symptoms of self-harm, leaving dysfunctional relationships, or managing their emotional dysregulation. But where these therapies may also sort of differ from each other is when you explore the why of the symptoms. And that's when you realize that the other criteria of PPD, such as emptiness, sense of identity, loneliness, sort of abandonment, as well as their response to the trauma that they've had. I'm unsure if they get checked in many of the quantitative studies, RCIs, etc. So then I wonder if the quality of these studies may be challenged because not all of BPD then is understood by the researchers, by clinicians. So I'm also sort of wondering, because then the question is also whether these studies then wait for clients to be relieved from their sort of abandonment defenses of splitting, or develop, quote unquote, healthy identity, or are we looking to bring them to a functional stage or to a point where their quality of life gets better? Because that's also what most of the scales in the studies look for as well, if their quality of life gets better. So what then becomes the goal?
Look, all the treatments that we have as of today, they actually are treatments that can help people achieve remission, not recovery. They're not recovery-oriented treatments. We need to develop recovery-oriented treatments, but some of them tend to recover, but that is whether it is because of the treatment or not, we don't know. There are some good studies now which shows probably like treatments such as DBT and MBT may be slightly superior to the treatment as to the common factors treatment. But DBT and MBT have to be done in the way the original investigators conceptualized it to be. Then it is slightly superior, slightly. Most of the times, this is almost 95% of the times, that's my guess, when we do DBT or when we do MBT, we are actually not doing DBT or MBT or schema or for transference, any of those treatments in the way the original investigators intended that to be. So there is evidence that when specialist treatments are done by good enough average clinicians, it doesn't seem to work very well. However, when good enough average clinicians like us, when we do generalist treatments, it seems to work quite well. Because I don't know whether you people have experienced DBT specifically. There's so many things to learn in DBT, and it is so manualized. By the time one really becomes proficient and uses it in a therapeutic setting, in a very therapy relationship context, then you need to have that amount of experience and expertise to use it in the right context and not really take the manual, hold the book, and talk about things what is written in the book. If you've seen Marsha doesn't use a manual to talk. Or if you've seen Anthony Bateman doesn't keep bringing in a psychic equivalence or teleological concepts and things like that in every single conversation. He's just doing the psychological psychotherapy, which is he's connecting with the patient and doing the work, because all the concepts are all at the back of the mind. But most early career clinicians or clinicians who are not that well trained, that well experienced, tend to be manual driven. Then you're losing out on the therapeutic relationship. Remember, therapeutic relationship is 50% of the outcome. So that's probably the reason why it doesn't work as well. And so the superiority of those treatments is taken away, lost. And if you're to do that sort of a superior treatment for DBT and MBT and schema focused and all of those things, it requires a lot of training, years of. So is it really worth it? Then the cost benefit analysis comes in. For some of us, we maybe DBT is the one which works best in my hands, because my mindset requires a DBT framework to work with patient. Fine, that's fine. But let's not say that is superior to something else, because there's no evidence, at least as of today. Like you say, maybe in 10 years' time, there may be different evidence. As of today, we don't have evidence. And it is the same thing if you look at the entire psychotherapy literature, all psychiatric disorders. We know that non-specific factors are the ones which really work. See, treatment-specific factors, even from CBT, it's about 10-15%. It's the non-specific factors which affect the 80% of the outcome. We have known that all along. Why would it be different for BPD?
Thank you, Devanshi.
Yeah, I've been sitting with this perspective since a while, and I think about something that resonated with to me the most was the driver and the teacher analogy, not the teacher, sorry, the instructor analogy. And that just got me also thinking in terms of the resilience the therapist needs to build up on to be able to just be. And a lot of times it's just so harder to not do anything than to just be, right? Dr. Sathya, I think it is unimaginable how you've been able to do this for 15 years with a smiling face. And I really would love to hear more about your insights, perspectives, apart from supervision. what are those perspectives within the therapy room, outside the therapy room, those small insights, small agencies that you hold on to, or that you would recommend us to hold on to in order to for us to be able to do this?
There's a phrase that you take a chill pill, right? So take it easy. Really pay the patients on, see, when they are working with you, if they are in a therapeutic relationship with you, things will work out. You, as long as you're, basic things, you're non-judgmental, at least most of the times. You are boundaried and flexible, and you have limits, and you develop a shared sort of understanding, and you're truly empathic. Uh, so those are very basic psychotherapy skills actually seem to work. You don't need to really do rocket science kind of work. That seems to be good enough. Being good enough clinicians actually is enough. It actually brings out good enough outcomes. Most people get well and they're alive. So I think we get very anxious with people with BPD because they're talking about all sorts of things. And the rules for management of, today we didn't have time, rules for management and understanding of suicidal behaviors in BPD is completely opposite to what we do in depression, bipolar disorders, and other disorders. That's another thing that does the head in for us. Because if someone is talking about suicide all the time, how do you know when they're actually suicidal? Right? There is a bit of a problem there. So maybe it's up for another session. So just believe in yourself that it'll work, and you're all doing very good work already. And this is what actually Masha said, if you remember. That's what all therapists conclude at the end of the day.
Thank you, Dr. Satya. Pratipti?
Yes, ma'am, am I visible and audible both?
Yes.
Okay. First of all, thank you so much, sir, for this amazing, insightful session. And I would like to share a few things. There's like I am personally suffering from both borderline personality disorder and bipolar affective disorder 1. So I belong from West Bengal, and I came up with, speaking up because of specifically for Ankita ma'am's question regarding her question. I am under psychotherapy, medication, and counseling from the year of 2016. And just an experience I'm sharing that I literally spoke up and got comfortable with my therapist after 3 long years. And then gradually I built an interest in psychology, and I was an MBA HR and I was working in corporate. So then COVID came and I left my job, and I'm in a career break now, and now pursuing my career in doing MSc clinical psychology. And I would like to pursue with this line, but they with all the stigmas, means anything and everything, as I can say, even in the college, in the universities, when people get to understand, those who have a bit of understanding regarding any of BPD or BPAD, they get to understand that I have it, because there is no proper normalcy, that is I am having maximum of the time I am either uh, at most at the maniac level or completely in the depressed level. And because of I am under steroids because of my rheumatic asthma, and the psychosis went out of my hand almost. So I am under medications also. So gradually now I am understanding how the treatments are going, how it is working. And presently, as you cannot believe that I am actually being able to discuss on this. But there was a time when I was being completely unable to even speak up anything, whatever the problems or whatever the issues or concerns I was having. So the point is, as Sar said, that it will gradually occur as much as the therapist will try. Actually, as a point of view from the patient or the client, I can say we are also trying at our best. It is
Absolutely.
just that we don't become able to come up with the issues
Right.
because we don't get to understand what is happening with us. It is kind of a
Sorry,
Lost the voice.
yeah, sorry, I don't know what happened. Hi, Pratiti,
sorry.
and yeah, sorry, glad to have you here. I understand that, you have been going through therapy and all that. However, your question might be out of the scope of this forum because it's meant for mental health professionals. But we are happy to connect via email in case you have
Yes.
any queries or something, right?
No, ma'am. It
Right.
was just a sharing a session.
Right. Thank
Thank you
you.
so much. Thank you.
Thank you.
Thank you.
Thank you,
Sure.
Pratiti. I just had another question, if Purnima, you allow me
Sure,
a
sure,
minute.
sure, sure.
Sir, I also noticed, I just had a first session with a patient, and she was having a lot of anxiety, a lot of distress, just sitting like this in the session. So, going by the triangle of, first creating distress tolerance and making the patient continue therapy, because the patient was clearly stating that I've been, instructed by the psychiatrist to come here. I'm here, but I don't think I'll be coming back. So I felt teaching her relaxation would be a good start and letting her build rapport and find comfort in the session. But as soon as I tried to teach relaxation, the patient was like, oh, these are such new sensations for me. I don't want it. I am so comfortable being distressed and tight and stressed in my body that I don't want you to shift my
Yeah.
condition. How do you engage such patient? Because the obvious factor then in my brain was this patient is not likely to come back.
Yeah.
But if I try to help, the patient's like, no, don't.
It's possible that she may not come back. So maybe I can try and demonstrate if you wish, if you're able to role play. It's
Sure.
difficult to explain. Yeah.
Yes. So, hi, doctor. I'll kind of show how she was sitting.
I'm aware that you didn't want to come for this treatment, and you didn't want to come to see me. And I know that you're here because your psychiatrist asked you to come here, right? What shall we do? Got about 45 minutes, and you're paying me so many thousand rupees. So let's try and see. I'm happy to make the best use of this time, even if you don't want to come back again. That's fine. What do you
I don't think I will.
That's okay. What do you
I
think?
mean, she's also been telling me, like, I came last year, took medicine, then I left it. Then I came after 2-3 months. Then I took medicine for 2-3 weeks. I guess I don't know. I didn't end up coming after that. Now I came last week. She's again telling me for therapy. She told me to meet you, so I just came. But I don't know. This is very weird. This feels difficult. I don't know.
It's quite weird doing therapy. It's hard. You're right.
Like, I don't even know what to talk. And I'm so used to it. Like, everybody's left me. I'm so weird. But I'm okay. I just want to be in my room. I don't want to come again.
Yeah. No, that's entirely your decision. I respect that. Do you mind if I share some of my thoughts? Can I?
Okay.
My experience is that when people come for therapy, initially they feel very weird because no one is used to going and sitting and talking to a stranger about all sorts of things that's happening in our mind, all the private things. And most people find it hard. They're speechless initially, or they don't know what to talk. What I can reassure you, I'm not trying to convince you to come back. What I can reassure you is that over a period of time, you might feel comfortable to talk. You might.
I don't like talking. Just I get anxious when I talk to people. Like, this is very uncomfortable. I don't want to talk. Like, I would want to be in my room. Why do I have to talk? I don't like talking to anyone.
What makes it so hard for you?
I don't know. I'm a loner. I just, I've been alone since COVID, and now I don't even talk to my family.
Mm.
And these were like the actual responses because exactly what I said and exactly what I
I
got.
would give space. I would give space and get
Hmm.
her to. I would be comfortable giving space and silence. And I'm going to so what I would be doing, I would just let her talk, whatever she wants to talk, and keep validating. The only thing I would do in the session is validate. And I would keep validating again and again and again and again and again. And
But
even I
I
would
was
try.
only getting sorry, I was only getting these responses because I was trying to get her to participate in the therapy. If I was not talking, she was also just silent and sitting. So then what will I validate then?
That's okay. We can sit for a few seconds, few minutes, a minute or two, sit in silence and say, what shall we do? Should we sit in silence for some more time? I mean, if it is comfortable for you, I'm happy for you to sit silently. As long as it is not creating discomfort for you, I'm happy for us to be silent. But if you want to do something else, if you want to talk something else, you want to talk, if you want me to talk, very happy to do so. I'll let you decide.
I honestly felt as a therapist, the patient kept oscillating between a choice of let's not talk and then going like, okay, fine, you treat me, go ahead, tell me what you want to do. And as soon as I started talking, they're like, no.
So it's a very classic symptom of BPD, the ambivalence, right? And also see, we don't know what are the circumstances in which she has come. She has been forced by somebody to come, and she may not know anything about therapy. She might not appreciate therapy. Also, she's a loner. She doesn't want to talk. She's been in COVID lockdown for quite some time. All that you need to create is create a safe place for her, and try to find something to validate, believing that there is always something to validate. See, if she says 3 years she's been 2 or 3 years she's been alone, she's lonely, she finds it very difficult to talk, I would say that must be very, very hard. And I can understand why you wouldn't want to talk. Maybe if I was in your situation, even I wouldn't want to talk. Try and be go to the level of where the patient is at all times and try and validate and genuinely try not to force her to come back, and don't try to do any work to make her come back, because that's not going to help you. Your best bet is to just give her a comfortable, tolerable 20 or 30 minutes.
How do you draw the line between forcing a patient to come back and educating a patient that you really need to come back because that will help you?
That is your agenda. That's not her agenda. It's not going to work.
Okay.
So your best bet is to try and develop a human relationship.
But isn't our role also to make sure patients come back? Like I read that in the DBT manual that
You can try all those techniques. But see, when in DBT, it's very clear, patient has to be motivated. If the patients are not motivated, you can't really do anything. Or if they're ambivalently motivated for a few weeks or months, you can use techniques to improve the motivation. There is a different scenario. Here, this person is absolutely disengaged.
Okay.
So here, they wouldn't even come for DBT session. You can't. Here, the best bet for us is to create a situation. If you don't force her, then at the end you could say, what do you want to do? Do you want to come back? Then if she says she wants to come back, then take the DBT approach. Why do you want to come back? Isn't it very hard for you to talk? I'm going to keep asking you to discuss. And I remember, put all the problems. Then if she says, no, in that case, I won't come, then you jump onto the other dialectic, which is saying that, no, you can. You will be able to. You know what I mean? So that's sort of a dance. The DBT really does it beautifully well. But she's not there yet. So this session is just being human. You
Hmm.
just want her to trust you, and you want her to feel that you're not going to emotionally hurt her. The psychological space, safety needs to be created, and genuinely try not to convince. Because if she sees you as someone who's come, she has come with the agenda that, okay, you're going to force her, but she's very clear. Because remember the dialectic, if you force her, she's going to keep resisting it. So if you don't force, she's lost. She'll have to come up with something. And also tolerate the silence. It's okay. 30 seconds, 1 minute. And if it goes beyond, then you say, what shall we do? Should we be sitting silently? I'm okay. Are you okay? If not, one of us had to break the silence. You give me permission, then I'll talk. But if you're not giving me permission, if you're not allowing me to talk, and if you're not willing to listen to me, then you talk. If both of us don't want, if you're not letting me talk, and if you're not going to talk, let's be silent. Let's tolerate it. I mean, see, it's really, again, you want to keep the patient in the driver's seat. It's very tempting to sit on the driver's seat ourselves. Remember that car? We can take over and drive, but what's the point? We'll have to let that person drive, making all the mistakes. In the car analogy, that patient has just stopped the car.
I think it also comes back to the idea that we think they are unable and they don't know, and we will be the ones who will solve their crisis by teaching them skills. We keep going into driver's seat.
We cannot solve the problem. We cannot really be. It's honestly we can't. If we can, of course we would do that. See, that's why the rule is different. In depression, okay, you do CBT, you do this, you do that, you give medicines. See, the entire change technology in health sciences is towards, we do something, get the person better. That doesn't work. We both will have to work together. And that person needs to be willing to invest in getting better.
Thank you so much. Thank you for that perspective.
So if you just accept those rules, it becomes easy to work. Then you're not stressed in that session. If you're not going to try to convince the person to come back, then you're just going to have a very easy, and probably, in fact, that will improve the chances of her coming back. And also, you're not stressed. And it's not your responsibility. You can't.
Thank you, Dr. Sathya. We are almost there. It's almost full, or actually above time. So on behalf of the Green Oak Initiative, I would really like to thank you for such an enriching and interactive session. I guess we all thoroughly enjoyed it, and there had been so many questions that left unanswered. But it's always the next time. I would like you to come again and share your knowledge with us. Till then, thank you so much.
Thank you.